cancers yet. Whatever I talked about was what? Adenocarcinoma. Okay. Squamous cancer of the esophagus is where is it located? Upper 1/3 of the esophagus, or upper half, somewhere there. Now, what structures are related to the upper esophagus? Trachea. Trachea. Anything else? Larynx. Okay. Trachea, larynx. Anything else? Recurrent laryngeal nerve. Recurrent laryngeal nerve. Anything else? Thyroid is way up here, yeah. But then this is pharynx. This is not the esophagus. Esophagus starts here. Thymus, not really. Yeah. Esophagus is the posterior mediastinum, and thymus is the anterior. Between them, there's many, many structures. Huh? Aorta, not really. The arch of aorta, maybe. Arch of aorta, yes. But I would say maybe left bronchus the most. Okay, and that's enough. Okay, now, with upper esophageal cancer, you're at risk of compressing the trachea or left main bronchus. In any aspect, any of those, when it's compressed, it will cause what? Dyspnea. Dyspnea. So let's put dyspnea. Larynx, again, larynx is way high up, so maybe not, but you could say that a recurrent laryngeal nerve or larynx, both of them compression, most likely a recurrent laryngeal nerve. Okay? If it's compressed, it will cause what? Yes, dysphonia or hoarseness. Very good. What were the symptoms of the adenocarcinoma? Thoracic duct or inferior vena cava leads to what? Edema. Edema or ascites. And compression of the aorta. What else was there?
The arrhythmia.
Yeah, the heart. I'm missing the heart. Left atrium. So arrhythmias. That's the two things you should worry about. That's it. Simple, straightforward. Nothing else to it.
Squamous, we have dyspnea and dysphonia.
Mm-hmm. These are complications, yeah. These are just complications. They don't have to always occur. Okay, if it occurs, that's what you'll be looking for. Okay. Okay, now, how would you diagnose them? If somebody comes with, what's the chief complaint of all three of them? Dysphagia. Okay. Gerd, maybe in the initial stages, burning, right? So now, when somebody comes with achalasia, that means there's an obstruction. What test would you do first? Okay, you know what? I'll do everything. Whatever you tell me, then we'll label them which one you do first. So endoscopy, sure. Barium. Manometry. Whatever. Biopsy. There you go. Anything else? Huh? That's good? Sure? Okay. Now let's do one more thing. 24-hour pH monitoring. Okay. I have to... You know what? I'm going to erase because now we don't care for them, right? We know the difference between the two. Okay, with achalasia, what would you do first?
Nitrates.
Now let's do this, guys. Now keep life simple. Whenever you want to test and diagnosis in laboratories, workup, you're going to do the simple one first, less expensive first, non-invasive first. What is the criteria? I'm telling you the criteria first, okay? So your focus should be on, so you're not confused. A test that is least invasive. A test that's non-invasive. A test that's not expensive. A test that's not discomforting. Okay? And a test that's very simple. Do those first. You don't want to discomfort the patient. If you can do something simple, you know, and you don't have to invade their privacy and so forth, why wouldn't you do that first? Simple, straightforward. Do a simple, non-invasive, non-expensive. Again, 3 criteria. Cost matters, because insurance and so forth, right? Cost matters for the patient, for everybody. So, less expensive, less invasive, or let's say non-invasive, and simple test. Okay, look for those things. Okay. Now, amongst those, which one is the least invasive? Barium. Barium, you have him swallow a liquid that is radioactively labeled, and then you will take an X-ray or CT scan of their chest. Done. Okay, simple. Yeah. So you will have him swallow a radio-labeled dye, or barium is the one that's labeled radioactively. Okay, barium is an element. When they swallow this, and then you will do an X-ray or CT scan, what would you find? So let me tell you. Okay. Let's say this is the chest picture, right? This is the chest, and here is the esophagus. Now on chest X-ray and CT scan, what is the color of air, like when you have lungs? Good. So here you will expect lungs, right? And here you'll expect lungs. So they should appear what color you said? Dark. And let's do that. Dark. So the lung will be also dark. I'll just slightly make it blue as long as you see it. But they're dark, right? And maybe you will see like slightly, let's just do it completely dark. Dark, dark. Okay. Maybe you'll see like lines that are like ribs. A little bit here and there. Now the area that is actually labeled with radioactive dye, it should glow. It should glow. It should glow white. Exactly. Okay. Now, if there is an obstruction, to esophagus, that means you will come down in this area. The esophagus should be dilated. Wouldn't it be? Shouldn't it be? Because there's nothing moving. It's just being accumulating and accumulating there. The stomach should be dark. The stomach should be dark because there's not much passing to the stomach. If it is a small amount here and there, you might see. Okay, so you might see a little bit being passed. So it wouldn't appear as nice round. Because there's still some passage, it doesn't mean there's nothing passing. So in this area you will see something sharp like this. Okay, and it's communicating with the stomach. And this is called bird's beak. I mean, I didn't draw it properly, so you should see something like this. Bird's beak appearance. Okay, that's what you should see.
Why did you make the stomach small?
Because there's not enough food passing through. If it doesn't pass through, it will not glow. Okay? I'm not saying it's small. It's just you can't see it. Yeah. Yeah. Okay? Let's choose a different color for it, for stomach. So you will see the stomach, but the area that is where the dye passed to is the area that's only glowing. Okay? Alright, so look for bird beak appearance, and that will help you. And on the cover of that page, you see it, right? Okay. So the esophagus we're going to see. Proximal esophagus is narrow and collapsed. Distal esophagus is what? Dilated. Okay. Now, the LES is narrow. Esophagus proximal to LES is what? Dilated. Esophagus now is different. It depends how I term it. When you talk about esophagus itself, esophagus is the beginning, the middle, and the end, right? Because it starts from where? From right here, from your neck. So this area, the first 1/3 is proximal esophagus, and it's middle esophagus, and the last 1/3 is distal esophagus. But that's talking about esophagus itself. When I talk about esophagus in relation to LES, then it's a different game. Then we start from LES. So the segment that was originally distal compared to LES is proximal. So when I use the term proximal to LES, the esophagus is dilated. Distal to LES, the esophagus is collapsed. Okay, so be able how to read things. Okay? All right. Now, in Gerd, what would you find on barium? So here you said bird, beak. What are you going to see for Gerd? Nothing. Nothing. On barium, you can't see anything. Yeah. Unless it's stricture. Unless it's stricture. So let's go that far. Okay. Unless there's a stricture. Esophageal stricture. Gerd, barium should be normal. For Gerd, barium is normal. No, nothing should be seen. Unless it's advanced, late Gerd. Then if there's a stricture, you will see what? Esophageal obstruction. Okay, it wouldn't be nice smooth like bird's beak, but it would be like this. Maybe a gap here and here. So let's see if I can do this. So all around the esophagus will be dark. The esophagus will glow. And let's say here's the stomach. And then you will see these. You will see the stricture is usually not uniform. So there will be like gaps where food can leak through. Okay, that's stricture. So, but of course, what will help you the most with Gerd is the history of Gerd. So no one's going to test you on something you can't answer. Normal. Esophageal cancer, what would you see on barium? Obstruction. So you will see a mass. Where? Okay, let's do both. This is esophagus. Okay. Now where would you see the mass?
Inside the bending.
Luminal mass. Excellent, luminal mass. Now let's do this. Here is the mass. So the only area that's glowing is what? Because the mass is obstructing. Here, same thing. At the end of it, doesn't matter which one it is. The location is what helps you where the mass is. So if I were to do this, what does this appear like? Apple core. As if you took a bite of apple, right? From both sides. This is called apple core appearance. Focus on the white part, not on the dark part.
Like kissing ulcers. And the fillers.
Yeah. Okay, so it appears like, uh-oh. You took a bite of apple. Let me show you, because the surrounding should be what? Dark, right? So if you focus on this, as if, you know, when you take a bite of apple and just the core is left. Okay, that's what you will see. Now be aware of the terminology that I used. Apple core appearance, apple core esophagus means what? Cancer. Cancer. If the apple core esophagus is lower esophagus, it's adenocarcinoma. If it's upper, it's squamous. It's squamous. If bird beak, it is what? Achalasia. If it's normal, Gerd. So that's for this. Okay. The next thing you can do is endoscopy. It's okay. You can do endoscopy. Let's say you do endoscopy. What would you see on endoscopy for achalasia? Yeah. The scope will not pass through. The scope will not pass beyond esophagus. The scope might not pass beyond esophagus. The scope might not pass beyond esophagus. Further, a scope, meaning there's a tip and there's a camera at the tip of the scope. And you can see everything inside esophagus. So you will see there's irritation and obstruction. So that's all. Whatever you see, you're going to interpret it. If you can see inside esophagus, you're going to see, wow, in the bottom of the esophagus, at the location of LES, the valve is closed. That's what I'm going to see. And maybe there's some irritation and redness. Okay. But at the same time, if you go as far as doing endoscopy, you might as well do what? Biopsy. You might as well do biopsy, because the scope would have little teeth that can take a sample of tissue. And when you do biopsy, what are you going to find for achalasia? That means you take the tissue after biopsy, you look under microscope. What would you see? Lack of myenteric plexus. It is endoscopy that confirms the diagnosis. So there will be myenteric plexus. Myenteric plexus deficiency. I'll put a negative because I have no room. Lack of myenteric plexus, or defective myenteric plexus, or less. And that confirms it. You're done, because you know the exact underlying cause of achalasia is what? Myenteric plexus defect or deficiency. Done. Move on. You don't have to do pH monitoring for this. You can further do manometry if you wish to. Manometry should be done before biopsy if you want to do it. Manometry simply tells there's high pressure.
No, peristalsis.
Yeah, it just simply tells there's high pressure. Okay, now I'll show you manometry. Okay, just remind me. I'll show you how it looks, because I need more room. If you do endoscopy for Gerd, what would you see? Inflammation. So you will see there is metaplasia. You will see metaplasia. You will see inflammation. You will see irritation. And you will see the LES is what? Open, slightly open, partially open. It's not closing completely. All of this makes sense. Just remember those. And then further, you will also do biopsy. You might as well do biopsy. On biopsy, see, metaplasia in endoscopy is very difficult to see, but you will see something if you're trained enough. But biopsy will for sure shows you metaplasia. Metaplasia. And that should be called gastric metaplasia, meaning the esophagus epithelium changed to gastric epithelium, gastric metaplasia. Okay, at that point, you have to monitor this patient on yearly basis to make sure that metaplasia does not progress to cancer. Okay? But before you go to endoscopy and biopsy, I will do this second. So first we did barium. If you wish to do for Gerd, I wouldn't do it. My first exam will always be 24-hour pH monitor for Gerd.
Nitrates, see,
No,
keeps the valve open longer, see.
no. You do that for heart. You don't have to do it here. What you can do is you can do Bernstein's test. You can give them acid to see if their symptoms increase. You can give them something acidic. Okay? But you do 24-hour pH monitor. You'll put a little pH indicator in there for 24 hours. And then if it's a litmus paper, if color changes and it indicates there's increased acidity, it's reflux, then it will be indicated on that paper. So 24-hour pH, that means there's increased pH. The pH should be decreased. So the pH of esophagus should be less. It shouldn't be, look, pH of esophagus should be about 7.4. Now when it's 6 or 5, that's not good. That means there's acid coming. Yeah. Okay. Over 24 hours of monitoring, you will see that there's less pH. The pH of esophagus is lower. Okay. Manometry, you don't do it. Do not do manometry. But then you will do endoscopy and biopsy after that, after the pH monitor. You can also do, for example, Bernstein's test, which is you give them acidic solution, and that should increase the symptoms. But of course, there are triggers for Gerd. You don't even need to do anything. Now, in practice, when somebody comes, they say, you know, I have heartburns. And my heartburn increases at night when I lay down, when I eat too much food. Not eating food. It's not true that it would increase intake of food, it increases. That's not true. Too much food. Now imagine if this is the stomach, and that's the esophagus, and I fill up the entire stomach with food. What is the likelihood of acid to reflux now when you have a full stomach?
About 100%.
Yeah, very high. Especially when you eat too much food before you go to sleep. And most people, you know what they do is they work hard all day. They come home and then they're like, the first thing to do is jump on their fridge and open them, and they just start engulfing and phagocytosis. Excuse me. And they start eating, and then they're knocked out because they want to go to sleep too, faster. Food makes you go to sleep because it decreases blood supply to your brain. And now, not only you ate too much food, Not only is your stomach full, and not only that, but you also lay down. The likelihood of reflux is now even higher. So usually, GERD is because of your habit for 10, 15 years, what you have been doing. It is simply habits. Now, there are some triggers that will cause the valve to stay open longer. Chocolate, smoke, coffee. Okay? Those are some things that will keep the valve open longer. Of course. Yeah. Those things. So if people have GERDs, you're going to tell them, please quit smoking. Decrease your intake of alcohol. And don't eat late at night. If you do eat, don't eat too much. Eat a little bit. Just enough to satisfy your energy needs. And then if you do eat, even if you eat little, you're going to stay up at least for minimum 1.5 hours. You cannot lay down. You have to stay up and sit, watch your TV, whatever you do. I mean, it'd be good if they study for their exam, but, you know. So have them, make sure they don't go. You have to give them that advice to prevent progression of this to severity. Okay. So that's what you will do for this. Now, once you determine that there is increased pH, the best thing is lifestyle modification. You don't have to give them antacid immediately or proton pump inhibitor. You can do those medications. I'll come back to management. But lifestyle modification for GERD. Esophageal cancer now. Of course, you're going to see apple core on barium. When you do endoscopy, what would you see? Luminal mass. Very good. Luminal mass. Luminal mass. Rough-looking luminal mass. Rough-looking luminal mass. Okay? And then you will do biopsy. Now, manometry you don't have to do because it will not help much. Now, when you do biopsy, what are you going to see?
Glandular epithelium carcinoma.
Yeah, you're either going to find glands or squamous cells, depending where it is. And that will confirm. But not only that, you can find squamous cells regardless. It's normal. It doesn't mean cancer. Glandular cells does not mean cancer. It could just be Barrett's. So what are you going to see to confirm that this is cancer?
Oh, non-differentiating cell.
Yeah, you're going to look for anaplasia. Anaplasia. Ana Munir. La anaplasia. Okay, now. And what else are you going to see? Dysplasia.
Isn't anaplasia the lack of cell growth?
Abnormal. Unorganized. Uncontrolled. Yeah. These two are the typical signs of cancers. And then you might see increased mitosis. You will see cells that are disorganized, unorganized. You might also see cells being in different stages. In different stages of mitosis. Meaning some cells are in the anaphase, some in metaphase, some in this. Again, that means increase in mitosis. Okay, so look for those things. And that's true of all cancers, guys. All cancer, these criteria should, whenever you see these criteria, these 4 criteria, it means cancer. Simple. No matter where it is. These are characteristics of cancer or neoplasia, which you're going to do at the end of this term, right? These are characteristics of cancers. But now, if you see this in squamous cells, if squamous cells are having anaplasia, dysplasia, increased mitosis, then you're going to think of squamous cell cancer. If you see this in adeno cells, glands, rich in these things, then you will say adenocarcinoma. Okay, so that's on biopsy. You're going to see this on biopsy. Okay, you don't have to do 24 hours. Yeah, there you go. That's done. Now let's do a treatment and we'll move on to something different.
Can we go over the manometry?
Yeah, let's do manometry. Although I rather do manometry later onward because manometry is done for scleroderma and crest as well. So when we do manometry, they should be labeled, okay? Things should be labeled for you. For example, generally speaking, in LES, this, and I will give you normal first.
Oh, that's what those little things inside are.
Yeah. So look, the tone of LES normally is increased, right? That means it's closed. Okay. Now, in achalasia, the tone should be higher. That means achalasia. Now peristalsis is a wave like this. I'll refer to as esophagus, the length of esophagus. As you go down the esophagus, you see the wave increases and then decrease, increase, decrease. So the wave is moving down. So that could be increased. Okay. For Gerd, now, so I should have given you normal here, yeah. For Gerd, it might be this. It's less. There's less tone. It's usually open. Okay, it's usually open. Now this was normal, right? So I should move normal to this side. Let's move normal here. These are normal. This is normal. This is normal. Now for achalasia in the esophagus, actually the tone is chaotic. And it doesn't contract properly. So it would be this. Yeah. Okay. So now in Gerd, the tone of esophagus is perfectly normal. It's only the LES tone that's decreased. Look, when we talk about graphs, a horizontal line indicates 0. Above that is positive or increased. Below the horizontal line is decreased or less. So you should be able to interpret these. In cancer, everything is normal because it has nothing to do with the tone of, right? There's just a mass. Okay. Okay. Let's move on to what are the other diseases?
Boerhaave, Varices, and Mallory-Weiss.
Okay, so Boerhaave,
Varices, and Mallory-Weiss.
Mallory-Weiss syndrome or disease or tear, and then we have varices, right? Esophageal. Okay. What pages are they on?
Mallory-Weiss,
29. Varices,
31. And Boerhaave, 33.
okay. I compare them because they present similar, that's why. The reason I'm comparing these three and compared to other three, because they present slightly different. When we talk about Gerd or achalasia, they're simply disease of what? LES. What's another name for LES? Where is it located? It's LES, lower esophageal sphincter, that's true. Where is it located?
In the end of the esophagus.
Between stomach and esophagus. So what would you call it?
Gastroesophageal junction.
Not junction. Sphincter. Yeah. Yeah. Gastroesophageal sphincter. Or valve. It's okay. Okay, so Boerhaave. Now, what I'm going to tell you now is the most important thing. Okay? You can figure out the symptoms. Never worry about symptoms and complication. You can figure them out on your own because you're very intelligent. What you need to memorize is the name, underlying cause, and path. That's all, which you were supposed to do yesterday, right? So we have a quiz coming up soon. In Boerhaave, it's transmural tear. Transmural tear. That's all. But I'll tell you what transmural means. In Mallory-Weiss, it is mucosal tear. esophageal varices, it is vein rupture, which is a severe case, but vein ruptures or vein dilation. Dilatation. Some people use this term, dilatation. In any case, you know, dilatation happens first and then rupture, right? Okay. If you remember that, oh my God, you're done. I mean, look at it. 2 words, seriously. Name and underlying cause. That's all. But let's go to this. Transmural tear means the entire thickness of the wall of esophagus. So it's esophageal rupture. So you can call this esophageal rupture. It's actually esophageal rupture. Transmural means the entire thickness of the wall is actually torn. Transmural means across the wall. Across the wall. If it's tear, means the entire, yeah, all 3 layers are involved. Serosa, mucosa, and muscularis. All 3 layers are torn. That's transmural tear. But the best term for that would be rupture, esophageal rupture. For you to understand, call it esophageal rupture. But make sure you know this term known as transmural tear. Now, Mallory-Weiss mucosa, mucosal tear. Okay? Yeah. Only mucosal tear. It's not esophageal rupture. It's like a scratch in your skin. It doesn't mean now suddenly there's a hole between your cheek and your mouth. If there's a hole, it is what? Boerhaave or transmural. If it's just a superficial tear, it is Mallory-Weiss tear. Okay? The most common location of Mallory-Weiss tear is lower esophagus. Let's talk about locations now. In your book, if you see MCL, it stands for most common location. Most common location is lower esophagus, okay? Near the LES. The most common location is LES, or lower esophagus, okay? The most common location for Boerhaave is what? The lower middle. The lower middle, where it's not protected. So the lower middle, okay, where it's actually exposed. Esophageal varices, always lower esophagus. Always lower esophagus. Okay. But now here comes your anatomy. These veins around the esophagus. Okay, so let's talk about this one first. Around the esophagus. So this is oh, that's not a happy esophagus. See, the lower esophagus has veins. Are veins superficial or they're deep? So what layer are they connected to or in touch with? Cirrhosa. Cirrhosa. These are superficial vein in cirrhosa. But they will go from there into mucosa. They will penetrate. Okay, so they're also part of the wall. Okay. Now, see these veins. Now there is left gastric vein. Left gastric vein, and it will give you these plexus. Okay, and then let's use a light blue. Right gastric vein. This one, yeah, let's just go. This is the left gastric vein. So one is right, one is left gastric vein. The 2 will form this plexus. Plexus means network. So anastomos. There's the thing. The left gastric vein is part of the portal system. Okay? Remember this. The left gastric vein is part of the portal system. Portal system. Portal. P-O-R-T-A-L. Portal system. The right gastric vein is part of caval system or systemic vein. Caval system. Caval means cava, vena cava. So you have 2 types of veins in the body in general, at least in the abdomen, vena cava and portal vein. So left gastric vein is a branch of portal vein. Right gastric vein is a branch of vena cava or hemizygous, which is again eventually goes to vena cava. There's a huge difference. Portal vein is supposed to drain fluid out of the abdomen. Vena cava is supposed to return to the heart. But nonetheless, portal vein always goes through through the liver. Portal vein, always, it will go through the liver. Is that okay? Just remember, we haven't talked about liver yet. So if this is portal vein, the portal vein drains into liver. It will drain into liver. But in the cases of liver cirrhosis, when the liver is cirrhosed, that means the liver is stiff, rigid, and the portal vein, actually, this is what happens with portal vein when it goes to liver. It spreads. It gives it these many branches. Okay, it spreads. It gives it many, many branches. It ends in the liver. Portal vein ends in the liver. But portal vein will carry blood in this direction, into liver. It carries blood in the direction of the liver. So it carries blood from the entire. So portal vein will carry blood from the intestine, from spleen, from stomach, from all those areas. It will carry it where? Into liver. So I'll put the arrow in this direction. Oh my God, what's wrong with me? Let's make it a perfect arrow. There you go. Now it ends in the liver. And then from the liver, the portal vein will, there's venous vein, hepatic veins, they will join together, make one large vein. And that is known as hepatic vein. And it will drain into vena cava. Let's see, this is the vena cava. Okay. So, as long as there is an obstruction somewhere, if there is an obstruction somewhere, what color should I use?
Green. Yellow.
Yeah, green is good. Yellow will, on the white background, might not be able to see. If there is an obstruction here, that means blood is not passing beyond portal vein. It's going to pull where? In the portal vein. If it pulls in the portal vein, what happens to the left gastric vein? It will engorge. It will dilate. Because now it's holding a lot more blood. It will distend. It will dilate. It will become weaker. That means it's at risk of what? Rupture. It's at risk of rupture. Okay? So that's one place. What if there is destruction of... So that's one thing, you have hepatic vein thrombosis. So one cause, I'm giving the cause of esophageal varices. Please remember that. This was hepatic vein, HV. If you obstruct hepatic vein, there'll be increase in portal hypertension. At the end of the day, we want the underlying cause of esophageal varices, portal hypertension. Memorize that. So I want to discuss what are some risk factors that can increase portal pressure. Okay, let's start from the top. One of them is hepatic vein. Now, hepatic vein obstruction. Hepatic vein obstruction. So, and that will be caused hepatic vein thrombosis. Hepatic vein thrombosis. So this right here is hepatic vein thrombosis. When there's thrombosis in the hepatic vein, that means blood is not moving along, so it will start pooling where? In the portal system. Essentially, it will increase engorgement, dilatation of esophageal varices. Esophageal varices is nothing more than a bunch of veins in the lower esophagus. Okay, so they will engorge, they will dilate. Good? So that's one cause. But what if there's hepatic cirrhosis? Hepatic cirrhosis means destruction of the hepatocytes. So these small veins within the liver, they're destroyed. If they're destroyed, that's almost like cutting all the highways between here and downtown. How are you going to get there? There'll be traffic jam. You can't go beyond that point. So when there's traffic jam, again, traffic is moving from blue into liver. So blood will start pooling where? In the portal vein. So the second cause is hepatic cirrhosis. Hepatic cirrhosis. So the first cause of portal hypertension was what? Hepatic vein thrombosis. Hepatic vein thrombosis.
Thrombosis is more common.
No, cirrhosis is more common. I'll give you the risk factor too. See, hepatic thrombosis is a disease by itself. We'll discuss that in the liver. Cirrhosis is a disease by itself. We'll discuss that in the liver. For now, just memorize two terms. What are two major causes of portal hypertension? That's all. What is the major cause of portal hypertension? Two at least, hepatic vein thrombosis and liver cirrhosis. That's all. Those two will lead to portal hypertension. Why? Because blood cannot pass through liver. It will start pooling where? In the portal vein, and it will distend, and it will dilate. So the pressure will increase, and that's called portal hypertension. Okay. So these are two major causes of portal hypertension. And portal hypertension will lead to what? Esophageal varices. Okay? Now, esophageal varices simply means, it doesn't mean that they have to be rupture. It simply means the veins here are dilated. They're expanded. They store a lot of blood. And then when something expands, what happens to the wall of that structure? They become thinner and weak. They become thinner and weak. And therefore, they're at risk of rupture. See, esophageal varices can be a silent disease. You don't know. You have no issues. It's just the veins are dilated. You don't even know. You don't even know. The problem is when it ruptures. When these veins rupture, then you lose tremendous amount of blood. So at the end of the day, esophageal. Who was saying I mix F and P? That's true. Esophageal vein dilatation, it's asymptomatic. It just expanded, weak vein. But esophageal vein rupture, that's a problem. It's the rupture that's from. But what I want to show you that, you know what, esophageal varices does not just mean it is rupture. When they rupture, when they explode or rupture, it becomes symptomatic. But before that, they're just dilated. So expect both cases. Okay. Now, when it ruptures, what happens? You lose a lot of blood, right? There's blood loss. Okay, so what do you expect the symptoms now? Huh? Anemia is okay, hemoptysis is okay, hematemesis is okay, melanoma is okay, and shock is okay, hypotension is okay, good. Okay, but let's talk about the major things first. All of that's correct. So when they lose blood, when they rupture, that means the blood will be in the esophagus. The person will have tremendous vomiting. And this vomiting is all blood. What's the term for bloody vomiting? Yeah. Okay, so there's a lot. Look, it's not a little, it's a lot of blood. These veins store a lot of blood. They're big veins. So that's one thing. When you lose blood, what happens to your heart rate? Why would heart rate increase when you lose blood? To compensate, to pump more blood because your body needs it. What will happen to your blood pressure? Blood pressure will decrease. So now these patients will have hypovolemic shock. And when your brain is not getting enough blood, what happens? You pass out. Syncope. What is syncope? Yeah. Syncope literally means you pass out. That's what it means. You pass out because there's not enough blood reaching your brain. Okay. So this is a hypovolemic shock. So look for the patients now. The question is, these patients usually vomit. Patients who are alcoholic, they vomit in the first place. Okay. Now, this requires alcoholics. Make sure alcoholic or cirrhosis. This is prerequisite for it. Or hepatic vein. Hepatic vein. Thrombosis. Look for those things. Look for those things. Okay. So esophageal varices are more likely in chronic alcoholics or hepatic vein thrombosis, one of those two. When it ruptures, the person is usually passed out on the floor, covered in blood, and they might be dead. Because if somebody's there, they might take him to the hospital, call 911. But if there's nobody there, they're by themselves. Usually the question back in the days used to come that the person will be always passed out in the bathroom, covered in blood, near the toilet, as if they went there to vomit, and then they didn't make it that far, and then they had hypovolemic shock and they passed out, and they're covered in blood and dead. That's a typical case of esophageal varices. But not, I shouldn't say esophageal varices, esophageal varices rupture, to be more accurate and specific. Okay? Esophageal varices rupture, the patient is always found covered in a lot of blood in a bathroom, near the toilet. Maybe there's some vomiting as well, and they're dead. If you find them alive, they should have tachycardia and hypotension. If you don't, then there's nothing you can do. Okay, so now, Mallory-Weiss tear. It's a mucosal tear. And a mucosal tear is going to do what? Just bleed. So this person will be only complaining of bleeding. But bleeding is, look, esophageal varices is bleeding, so is Mallory-Weiss tear. Mallory-Weiss is tiny bleeding, not a lot. When they actually vomit, the vomit might be tinged in slightly streaks of blood compared to all blood. Huge difference. Don't confuse those two. Mallory-Weiss is just simply a small tear in the lower esophagus that when you vomit, the vomit will be covered with tinges of blood or streaks of blood. Okay. Now one more difference. Venous blood is dark. Arterial blood is what? Red. So in Mallory-Weiss, it's fresh red blood. And esophageal varices is dark, old blood.
So Mallory-Weiss is arterial bleeding?
You can say capillary. It's more fresh blood, yeah. It's not venous, it is arterial. The capillary end of arteries. Arteries are too big, they're not there. So in the mucosal area, you have only capillaries, yeah? Okay. Now, so look. Esophageal varices, blood loss, tachycardia, tachypnea. What's tachypnea? Rapid respiratory rate or breathing rate, okay? Hypotension, tachycardia, tachypnea, and vomiting of blood, pure blood. Done. No question asked, okay? When it comes to Mallory-Weiss syndrome or tear or disease, there's nothing more than just streaking of blood and vomit, that's all. Just focus on that. Let's come to Boerhaave. And then I'll tell you what's the risk factors, okay? We'll talk. Now, if the esophagus ruptures, now, the entire esophagus, where's the esophagus located? Thoracic cavity. If it opens up, if it ruptures, if it bursts, what will happen to food?
Goes in the
It's going to spread and leak into the thoracic cavity. Now you have food around your heart, near your lungs. You don't want that, do you? Now, where would this food be? In the pleural cavity? In the mediastinum. Good job. Posterior mediastinum. Posterior mediastinum. Where you have aorta. Where you have thoracic duct. Where you have vena cava. And where you have the wall of the left atrium. And the food will eventually leak into the pleural spaces as well and so forth. Okay? Now, do you think that should be emergency or no?
Yes.
Yeah. Yeah. You don't want food in the in the thoracic cavity. You want them in the stomach.
You also have all the venous plexus blood pooling in there too.
Venous plexus blood?
Sorry, the esophageal plexus.
No. Now, when the vein ruptures, it's different than when the wall ruptures. The wall will have one or two veins, superficial. But when the vein itself, that's dilated rupture, it's more blood loss. So this is like...
Okay, so it's like a hole in the wall.
Yeah. Yeah. Okay. Transmural tear. Transmural tear. There is a tear of the entire thickness of the wall. It's not venous rupture. It's wall rupture. Wall will have some basic capillaries here and there. Okay.
So it's more fluid than blood.
Yes. Rarely it's blood. Rarely. Okay. Now, what would the patient complain of? Look, here they were going to complain of hematemesis, right? That's what they're going to complain of with Mallory-Weiss tear. That's all. In the esophageal varices, they might not complain. They'll be passed out and done with. There's no room for complaint. Now, what are they going to complain of Boerhaave? Chest pain. Let me go that first, and then I'll move to Mazen. Chest pain. Don't forget, Mazen, what you're going to say, but let me just give him more chance. This chest pain. What about this chest pain? Can you tell me a little bit more about it? It's sudden. Very good. And it's what? Sharp? Sharp. And how would it feel?
In the middle of the back.
I like that. Radiating to the back. Look at that.
Like
Amazing. Breathing to the back. Lower back, middle back, upper back. Middle back. If you say upper back, it becomes mostly aortic dissection. Lower back becomes lumbar vertebrae, okay, which is abdomen. So middle back. Good job. Now, anything else about this pain? You make the conclusion. You have the knowledge.
Severe resistant.
Severe? Sure. How would you define severe then? See, in this case, how would the pain feel? I was going to say, how would the pain feel? Tearing. It's tearing in quality because the esophagus is being torn. It'd be tearing pain. You can feel it, that it's moving down or slightly up. Okay, the patient will tell you. Yeah.
It said it increases with swallowing. So why would there be swallowing?
It actually caused by swallowing. So sometimes the tear can be there, but it's not complete, and the swallowing will make it complete. Okay? The patient should not eat, but sometimes when patient, they don't know what's going on. They think the food will decrease it. They think it's gastric acid or ulcer. So patient can do crazy things.
Just a minute.
Yeah.
The swallowing will increase it, or the vomiting will increase it?
Swallowing.
Swallowing.
Yeah. Okay? Now, there's the thing. So far, so good. That's the chest pain part of it. What else do you expect? You would expect food in the mediastinum. Food in the mediastinum. Not malnutrition, because this would be resolved the same day. Or you're going to meet in heaven and have a lot of food. So no malnutrition. Yeah. So in this case, you would expect this person to have what? Food in the mediastinum. When you have food in the mediastinum, what could happen to mediastinum? Infection. So media, stenitis. Very good. That is crazy, because it's just like peritonitis.
Very crazy.
Yeah, I must say, for sure. You know who shocks like that?
Sean Connery.
I love it. This guy knows me. Okay, mediastinitis is an emergency. That can lead to trouble breathing, arrhythmias, and a lot of problems because the whole chest cavity is now inflamed and infected. It's an emergency. What else could you look for? What else would you find in mediastinum? Air. 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 See, esophagus is connected to oral cavity. And oral cavity is connected to what? Outside. If it ruptures, air goes where? Yes, you can have pneumothorax. You can have pneumothorax, but more than pneumothorax, you will have subcutaneous. Yeah, you heard of that. Good for you. What is emphysema? What does emphy mean? Yeah. Emphysema. Emphysema simply means too much air, and air that there should be no air. Or should be less. So the neck will expand. The skin of your neck will expand. When you feel it, it will feel like there's air there, not water, not solid tissue. Yeah. When you press on a balloon, how does it feel? That's how it will feel. Okay. So you might have crepitus when you compress the skin. Okay, so subcutaneous emphysema is a big deal. Mediastinitis is a big deal. Chest pain is a big deal. That's all there is to it. Now, this is an emergency. So what's the first thing you have to do?
Fix it. Go to the
Operation.
Huh? Yeah. Yeah, don't fix it first, because you will lock the food in there.
Oh yeah, it's not bleeding.
Yeah. Evacuate the chest. So what do you have? How do you do that?
Endoscopy.
Chest tube. Immediate insertion of chest tube. Immediate. If you do endoscopy, what are you going to do to that tear? Make it worse. And guess what? Since you mentioned, that's good he mentioned it. Those who have you writing, go write it. Fast, fast, fast. And then I'll tell you. Okay. Chest tube is the first thing you have to do. Forget diagnosing. If you see these things on physical exam, immediate chest tube. But if you do X-ray and you find emphysema and the fluid and food in the chest, Again, a meaty chest tube. But now, let's talk about the underlying cause of these things, because he mentioned something. Somebody said endoscopy, right? Let's talk about what caused these conditions. Boerhaave, the most common cause is hospital-acquired. Boerhaave is mostly caused by who? By doctors. Careless doctors, untrained doctors, or just unqualified doctors. Somehow they got into residency. Who knows? Now, it is endoscopy. The most common cause is endoscopy. Believe it or not. The most common cause of Boerhaave is what? Endoscopy. Endoscopy, remember, you put a scope and the esophagus usually collapsed. And if you keep pushing and pushing and pushing, it could rupture, especially if there's an area of the esophagus that's really weak. So you have to be careful. If somebody has esophagitis, if somebody has Mallory-Weiss Tear, you don't do endoscopy immediately. You have to be careful. You have to call somebody who is experienced in that. So endoscopy. And what do we call disease that are acquired through a hospital? Nosocomial diseases, right? And there's another term. Iatrogenic. Okay? And nosocomial. So when you get a disease, now if you get a disease in a hospital, it's called nosocomial. If you get a disease because of a physician, it's called iatrogenic. It's a little bit different. Or because of a nurse. Or is it because of a technician, any human being, iatrogenic. Okay. Okay. So what's the most common cause? Endoscopy. Now, Mallory-Weiss Tear could also lead to Boerhaave. Sometimes it can get worse. Gerd could put you at risk. I mean, there's many causes. This is by far the most common cause. Now, you're smart enough. Anything that leads to weakness of esophageal wall puts you at risk of rupture. That's all. So, esophagitis. Where is the G? Esophagitis. Could also put that at risk. I mean, there's you can figure out many things. Okay? But anyhow, now, Mallory-Weiss Tear. It is acid reflux, HCl, reflux, plus vomiting. Actually, it's vomiting more than anything. It's vomiting. Okay, so now when you vomit, what are you vomiting?
Food and acid.
Acid. So let's focus on the HCl part of it. When people vomit frequently, the gastric acid has to pass through where? Through the esophagus. The area of esophagus that's most likely coming in contact with vomiting is which area? Lower esophagus. And the area that will come under more pressure is the lower esophagus, because usually it's closed. When you vomit, it's pushing against the sphincter, and it has to open. You're pushing against, you're putting pressure on it. So the intraluminal pressure is usually the most contributing factor ever. Increase intraluminal pressure. Increase intraluminal pressure. This is not the same thing as increase sphincter pressure. It's a different thing. When sphincter pressure is increased, it closes. When intraluminal pressure increases, it opens. Okay? Pressure inside the tube is different than pressure around the tube. Okay, so that's one thing. Now, who's at risk of vomiting frequently? Young girls. That's one thing. So young girls, and they are usually bulimic or anorexic. Okay, and then we're talking about male, it's alcoholic. So young men. And their risk factor is drinking. Girls usually don't drink crazy. They do just for socialization, a sip here and there. Guys, when they drink, I mean, some girls do crazy things too, but guys, when they drink, what do? They do binge drinking. It's binge drinking that causes vomiting. Okay? So repetitive vomiting will cause erosion of the mucosa, and this mucosa can bleed. and that bleeding will cause Mallory-Weiss tear. It's nothing more than just bleeding. But they should have a history of vomiting. If it's anorexia and repetitive vomiting, you would look for their fingers or bulimic. Their fingers should have teeth mark and acid burn marks on their nails because they induce vomiting, right? So look for, and they will have bad teeth, eroded teeth. Look for those signs. So I might not give you anything. I might just give you somebody is vomiting, and and I give you signs of burned nails, burned skin, and then I tell you what is this person at risk of Mallory-Weiss tear. Okay, so be understanding. Esophageal varices, we talked about it already. So these are risk factor or underlying cause of esophageal varices. Portal hypertension is the underlying cause. Portal hypertension, and the risk factor for this is cirrhosis and thrombosis of hepatic vein. Those are the two. Not portal vein, hepatic vein. Okay. Now, cirrhosis, who's at risk of cirrhosis? Mostly men. Chronic alcoholic men. Usually men are more alcoholic than female. Thrombosis, usually female. Okay, and especially those female who are using birth control pills, oral contraceptive pills. Plus, on top of that, they work out and they use steroids. No, not menopause. No. Young female. Okay, so
Estrogen was anticoagulant.
no, it's procoagulant. It acts as clotting factor and thrombotic event. So smoker, a female who's a smoker and who uses birth control pills, the chance of her having thrombosis is 40-fold increased. That's a lot. Okay. So they have more chances. A female who's birth control pills, that means too much estrogen, and plus smoker, of course, she's at risk of thrombotic event. Now these guys are men with cirrhosis, they are alcoholics. Again, don't expect all information on questions. As long as I give you chronic alcoholics somehow, and I tell you which of the following are more likely to occur or they're at risk of what? Esophageal varices. Bulimic patient, Mallory-Weiss tear. Boerhaave, endoscopy. You gotta know it that way. Okay, next thing. Before we take a break. How do you diagnose? Boerhaave, what are you gonna do? What's the first test you will do? X-ray. Chest X-ray. Excellent. Do chest X-ray. On chest X-ray, what would you see? Food in the mediastinum and air under the skin. Good job. Good job. Excellent. What test you shouldn't do?
Endoscopy.
Don't do barium. Don't do endoscopy. Why not?
Barium will spill into the spinal cavity, and
Yeah.
will make it worse.
Excellent. Barium will spill. You're introducing more food, but radioactively labeled food. Ha ha. You don't want to do that. Okay. And endoscopy will make it worse. Okay. So first, before you do anything, as soon as you chest X-ray, it's diagnostic. The next thing you have to do is what? Chest tube. Insert a chest tube. And evacuate all the food product from chest. And then you should wash the chest with antibiotic to make sure there's no risk of infection. Okay? And saline as well. So saline antibiotics. Okay, so once you do that, so first, second, then you can repair it endoscopically. Endoscopically, you can repair it as well, rather than opening the chest. You can go to the chest tube areas, but preferred endoscopy repair. So you can actually do it. And then, of course, for some time, they cannot eat per oral. You cannot have mouth food. Yeah. You can give them saline, fluid, in other ways. Yeah. And I'll take care of it. Boerhaave, if they survive. Mallory-Weiss tear, what are you going to do? How are you going to diagnose it first? Endoscopy. Barium. Would barium help you? No, it won't help you. You can do it to rule out something else, but it won't help. It might irritate the tear even more. But do endoscopy. In an endoscopy, what would you see? Linear tears. Linear. Vertical tears. Linear, vertical tears. Not horizontal. Not circular. Linear, vertical tears. because the acid is pushing what? Upward. Okay. So endoscopy, you will see these linear vertical tears in the lower esophagus. And that's diagnostic, that's good enough. Do you have to do anything else? If you feel like doing biopsy, knock yourself out. You won't find anything. Everything should be normal. Okay. Esophageal varices, what are you going to do? If they are asymptomatic, accidentally on endoscopy, you do endoscopy for something else, you might find esophageal varices, you see engorged esophageal veins. Or if somebody has cirrhosis, you suspect this, you might find something like that. And then you have to be careful and put them on diet, and they have to stop whatever they do, especially alcohol. Okay? And you can ligate them, you can cover them, you can do many things, which is not for you, because you guys are not surgeons yet, as long as, so there's no test to diagnose it. There's no test, actually. It's accidental finding, or they're passed out. You have only two options. Accidentally, you find that their veins are engorged. You find varices, or you find varices that are ruptured. And when they're ruptured, you will have clinical signs: tachycardia, hypotension, and maybe pass out and vomiting blood. Okay, so it's clinical diagnosis, not laboratory. Okay, how are you going to fix these things? So Boerhaave, you're going to repair it, right? Chest tube, repair, antibiotic, and done. Mallory-Weiss Tear, what are you going to do?
Cauterization, ligation.
Yeah, if there's too much bleeding, yeah, you can cauterize it, you can burn it, you can do it. But if it's nothing like that, you make sure you refer them to who? If they're bulimic, if they're alcoholics, refer them to psychiatrist. You can only prevent this. You know, you have to take that knife that cuts that area. Take the knife out of their hand. Okay, you don't give them medication and then tell them, please cut again. You know, so that's psychiatrist. Refer them to psychiatrist. Hopefully they will be able to help and deal with this issue. But if it's still bleeding actively a lot, then you can call a surgeon to ligate that area. Okay. Esophageal varices, if you find them still alive, you have to put them immediately. Now, in emergency, what are the rules in emergency? For children. It's for children. You have to teach them ABC first. ABC. In emergency, it's always ABC. What's A for? Airways. B for breathing. C for circulation. So you have to maintain and stabilize the patient first. Esophageal varices, why would you care for diagnosing and sealing that area before you have to stabilize them? Immediately put them on what? IV fluid. And then see if they're breathing. At least keep their airways open. Because if they're vomiting blood, what if it goes into the trachea? Of course it's going to go in trachea, especially when they're laying down. So secure airways. That's what A, airways. Secure airways and breathing. And put them on IV fluid. IV fluid. So A for airways. Secure your airways. Make sure they're open. They can breathe. And secure breathing. Now, if they have trouble breathing, maybe you have to put them on ventilator. Okay? But C is for circulation. Circulation, usually, the signs of abnormal circulation is low blood pressure and increased heart rate, which is shock. How do you restore blood volume and blood pressure? Give them fluid. If they lost blood, increase their blood volume by injecting fluid into blood. That's IV fluid.
So you give them blood as well?
If they're anemic and so forth, yeah, you might be able to do that, but it wouldn't be needed in those cases. So it depends. If IV fluid is not restoring anything, so you can give them, start them on packed RBC. But do this, stabilize, revive them first. Make sure they don't die first, then go further. Once you're able to stabilize the patient, then you might call a surgeon. Because look, what is the case of emergency physicians? Not to cure anything, not to do anything, it's just to stabilize enough for specialists to come and take care of the thing. Okay. All right. So once you do that, then you can surgically repair those veins, surgically repair them, and then that should be do it. But now that's not the thing. So if these patients survive, and you repair the veins surgically, further you have to create a shunt. A shunt. Porocaval shunt. Excellent. So that there is a communication between caval system and portal system. And the issue with porocaval shunt is they are at risk of infection. Now, those of you who have done microbiology, for you this is the question. For the rest of you, you research it. You should know it. People who have done micro, they should know it. People who haven't done micro, you should research it. What is the most common bacteria that causes infection of the porocaval shunt? Let me know. It is in the strep or staph family, one of those. It's not aureus. Okay, so search it. Okay. What else? For esophageal varices, of course, you can create a shunt, but that's not the cure. They must quit
It happens.
alcohol. They must quit. There's no option. Otherwise, they have to look for another liver transplant. So, okay, ladies and gentlemen.